Okay. So we've started. Next slide, please. So before we begin, I'm going to do a territorial land acknowledgement. So today we have the privilege of coming together on the unceded Musqueam, Squamish, and Tsleil-Waututh territories. May we recognize this honor and approach our work with honesty, compassion, and understanding. So a few agenda items. So this is a quick outline of what we'll be covering today. So a quick run through of housekeeping and introductions. I think most of us have been on calls with one another in some capacity, so it'll be nice and quick. We're going to go over the purpose of the meeting as well as some guiding principles, and then we'll get into the meat and potatoes of the validation. So Carmen's going to go over some user position, location, encounter type, medical services, devices, referrals, and registration. And then from there, we're going to do some future state end-to-end workflows, followed by some other follow-up questions by Carmen, and then we'll give you guys opportunities at the end as well as throughout our presentation to ask anything that comes up. And then at the very end, we're going to talk about the next steps moving forward. So we have a few housekeeping items. Please remember to mute yourself when you are not speaking. Please state your name when speaking to support proper meeting notes as well as follow-up items. If you have any non-urgent questions, by all means, please feel free to add those to the chat. During my section, when we talk about the workflows, feel free to interrupt me during my part. I have no problem with that. And then again, the session is currently being recorded by Zoom, so if there's any objections, please let us know at this time. Just a quick round of introductions from our Richmond site here. I think we only have two of you guys on the line, but our ICS provider is Dr. Sampath, who sadly is not going to be joining us. Bal is the perioperative service manager and director of the surgical program. I don't believe he's on the line, but we do have, thankfully, Jonathan and Ari. So Jonathan is our surgical project manager, and Ari is our lovely program assistant and clerk. I don't believe I saw Maria on the line, but she is our wound care clinician. If there's anybody else that's joined us in the last little while from Richmond, please feel free to let us know, and we can add you to our notes as well.
Sorry, Jonathan, you raised your hand.
Yeah, just be very mindful with Dr. Sampath's name spelling.
Sorry, yes, we will correct that. Sorry.
Yeah, not a worry for me. It's just if you were speaking with him.
Yeah, for sure.
Thank you for that. Okay. And then from the CST team as well as the site informatics team, we have our managers. Michelle is just joining us right now. She is the clinical informatics manager for the perioperative services. From the CIS perspective, we have Carmen, Morgan, and Maggie, as well as myself. We are the clinical informatics specialists for critical care. From the ambulatory team, we have Dolores and Rachel. From scheduling team, we have Manju and Josh. From registration, we have Andy. RSTQ, we have Andy Tutu. From med management, we have Tam. From the provider adoption team, we have Elena. And then we have Harmon from the PEC team as well. If there's anybody on the line that I've missed, please let us know. I'm going to add you as well. If not, we will move on and we'll just get into the quick purpose of this meeting here as well. So the purpose of this meeting is to validate the completed CST Cerner build and workflows for the RHS General Surgery Rapid Access Clinic. And this scope would include the registration piece, clinic visit, documentation, as well as discharge and follow-up workflows and processes. We've gone over multiple guiding principles in previous meetings that we've had together, but the one that we're going to focus on today is going to be guiding principle number 3 of CST design. And our priority is going to be on the must-haves. So as we approach activation and go live, we want to make sure that we have everything in place to ensure that we can provide safe and effective patient care. Certainly, there are opportunities to have our requests go forward to optimize this system, but the risk that we run is that if we overwhelm our poor builders with all these requests, we run the risk of not being able to have everything built in time for our activation. So let's get us to the finish line, and after that, during the sustainment phase, at that point in time, we'll focus on that optimization piece, but we want to make sure we get there in a timely manner first. So that's something to keep in mind when we're going over our workflows and going through this validation session. And from here, I'm going to pass this over to my colleague Carmen to get into the meat and potatoes of the validation piece. Thank you, everyone.
Thanks, Sally. So I'm going to go over the positions first. All right. So for provider, the position they will be provisioned with is a physician surgeon. The clerk program assistant will be given the scheduling clerk working monitor, RHS 01. Sorry, that is a mouthful, but that is the name of the position. And the wound care clinician will be just provisioned with the nurse wound ostomy position. This is allocated out regardless and not really a part of this clinic, but just to let you know. Any questions about these positions? If not, these are just standard positions, and if there's no questions, these will be validated. Next, we'll go into location. And I'll show you what this looks like in the system as well. But so for Cerner location, the facility will be RHS Gen Surg RA. And these are just the names. Unit description will be RHS General Surgery Rapid Access Clinic. And the unit display will be RHS Gen Surg RA. Room will be 1306A. Is this still the room that we're going to be using? Oh, yep, sorry.
Yeah.
You both raised your hands.
Yeah, sorry. I think operationally we had changed to a different room.
Okay.
1306B now.
Okay.
Apologies, I missed updating you.
No, all good.
Yeah, Ari, was
We
that
will
what you
update
were gonna
that.
say as well?
Yep, that's it.
Okay,
Thank
we
you.
will adjust that then.
Thank you.
Thank you very much for confirming. And there will be no beds. So other than the room being changed to 1306B, are the other naming conventions, do they look okay? And I can show you what this is kind of look like too. So apologies, this wasn't built prior to today, but the location basically will be RHS Gen Surg RA in the banner bar of the patient here.
I guess it can't be RAC, right? I think there's a naming convention or something. It can't be RAC.
Like GRAC, just GRAC.
Yeah, like Gen Surg RAC. Is that possible?
Let's see. Can I call upon?
Yeah, so there
our
are
vendor?
some limitations for the short name. I think we can only have 15 characters, including space limits. So, I mean, if RAC, like if the extra letter fits in that, then we might have to put in because now we've already sort of the core location team has already kind of done that work. We might have to put in like an EDD to have that changed. So that would be the other piece.
Okay. If it's not too much trouble, I would like to submit that request. And the reasoning is because I think for a site knowledge location, we've always called it GRAC, but having it called Gen Surg RAC would be just it will be more aligned. RA might just take a little bit of like accustomed to.
Yeah, okay, so I can have a look into it. I'll count the numbers that we have, and I'll see, and then we'll get it. Pardon me, I'll get an EDD started from our end.
Perfect, thank you.
Just from my preliminary like counting, I believe if we added a C, it would surpass 15.
Yeah, sorry, I just hadn't had a chance to count them yet. But if that is the case, then we would.
Do we take out the space at Gen Search?
I'll like get rid of the space.
Would
Yeah.
GRAC just simplify things?
The RHS space GRAC?
Yeah. Will that be possible?
I mean, that's much shorter, so that would work within the 15 character limit.
Okay.
I think what we'll do is put through the request. We'll certainly try, and then we'll let you know what the core location team says.
Perfect. Yeah, because I think for the site, everyone knows the clinic as GRAC.
Yeah.
So Gen Surg RAC would be okay, acceptable. I think it's just RA might take a little bit of information on adjusting to for the site, but not a big deal.
So first choice RHS GRAC, second choice RHS Gen no space Surge RAC.
Yes. Yeah, that would be perfect. Thank you so much.
And then we'll see if we can change all that at all. Because at this point, I think it's an EDD to get the change going through.
Yeah.
But worth a try.
Yes.
Thank you.
Thank you. And we did have a question too. Is this something that needs to also be validated with Dr. Sampath?
No, it's fine.
Okay.
I will run it by him, but I don't think we need to
Okay.
get his approval on it. Yeah.
Perfect.
Okay, sounds good. Then we will get that EDD in and keep you guys updated. I'm just going to move on then. Next, we're going to go into encounter types and the medical service. So these are the encounter types we'll be using. There will be the referral, which is for patients who are referred to this clinic. We have the pre-outpatient encounter, where the clerk pre-registers the encounter. And then the outpatient encounter for when the clerk or main admitting registers / checks in the patient in person. And this encounter will auto discharge at midnight. Any questions about these encounters? Hearing nothing, these encounters are then validated. And just to validate the clinical medical service that it is general surgery. This is correct.
Yep,
This
correct.
will also be validated. Thank you.
You don't have any other services that come through, like only general surgery, right?
Only general surgery, yeah.
Perfect.
Thank you. Moving on to devices. Most of this was checked in by device team. So things like the printer and the label printer, the device team is taking care of, and they are working on their end. So just to confirm, our decision previously was to keep one fax number, which will be a work Q monitor fax number, and the paper fax number. And this is the number 604-233-5654. And then the phone number for this clinic, 604-244-5470. Is this correct?
Yeah, I think I already thumbs up.
Yeah.
We're good. Yeah.
Okay, sounds good. Sorry,
Thanks,
I
Ari.
do not see this.
Yeah.
No, I got
clearly.
you. Yeah, I got you. No worries.
Thank you. And then for the requisition printing type, the standard build is IPPDF and auto printed paper. Requisition manager is something used mostly by BCCA, which has multiple requisitions at once. But for this clinic, we're going to use the standard build. And what this means is it's a requisition printing type used in Cerner to standardize and streamline the printing of recs for medical tests and procedures. The recs will print at the designated printer when something is ordered to be given to the patient at the time of the appointment. And there is also a PDF option available. I understand that not many tests are ordered at this clinic. So this is just the most appropriate option if there were tests to be ordered. Does that sound okay? Nothing.
Yeah, thumbs up. Thumbs up. Yeah.
Oh, sorry. Yeah. Once again, I don't see the Zoom.
No, I got you. Yeah, don't worry.
Thank you.
Yeah, I already got the thumbs up.
Sorry, I'll speak next time.
Oh, no, it's okay. Thank you. So, and then the next thing we're talking about is SunQuest. That is something we use for collecting lab specimen, and this is not something this clinic does. So that is a no for this one. And there's no single document scanning done at this clinic as well. Does this all look correct to you all?
Yes, it looks great.
Thank you. And the devices and the details are validated then. I'm going to move on to our work queue monitor. So the queue name will be RHS Gen Surge RA in brackets GRAC. Is there any, would you also like to change this? Or is this okay?
No, only Ari sees this, right?
Okay. Yeah, only Ari sees this.
Ari, do you like this name?
Oh, that's totally fine.
Okay,
Okay.
that's cool. All right, we're okay.
All right. Thank you. And then the document type will be the referral package, subject type also being the referral package, and the responsible position with access will be Ari, who's a scheduling clerk anyway. The this all looks okay, then this will also be validated.
Looks good.
Thank you. And just a reminder what the work queue monitor looks like. It's not in here yet, but it will be titled RHS Gen Surg RA bracket GRAC.
Sorry, with the name being that long, would it kind of disappear? Or will the name fill out the whole tab? Do you know?
I believe I might have to defer to my builders for this question. Either
Okay,
Rachel
no worries.
or
Yeah, I'm just curious, but it's fine either way.
yeah, or Michelle or Josh.
You
or-
know, I actually don't know. Yeah, or I don't think I've seen one that long.
Hmm.
Yeah, so I guess if it is long and it disappears, if it and then again, if it's not too many mountains to move to change it to just GRAC, then we can keep it at GRAC, but otherwise this is okay. So I think it's just a little bit of getting used to it, and for Ari, but she'll know like where the tab is, right? Eventually.
Okay.
So the preferred naming would be just RHS GRAC.
No, like I mean, like if it extends
Yeah.
way past, then maybe GRAC, but then otherwise we can keep it as it is.
Okay.
Let's not do too much work.
Okay. Right. We will investigate that as well. Moving on to referrals. I will go into more detail, but this is what the referral order will look like. So the order name, I will again go into more detail, but this is just the preliminary look. Referral to outpatient RHS general surgery rapid access is the name of the order. Within it, you have scheduling priority, and there is more options with the drop-down box. You would put in the provider. This defaults to no for research study. Special instructions would be entered by the provider, in which I will show you the reference text that pops up before they get to this screen. Yep.
Sorry, this is a very standard referral order
This is.
template, right? So we can't really take away the requested provider.
I also have to defer to my build team and Michelle for this.
I'm sorry, I missed the question. What did you say?
For the requested provider, is it a field that we can easily remove? If we can't, then that's fine because it's not essential to the order anyways. But I think because of how GRAC works, I think having the requested provider might be a little bit confusing.
No, that'd be a standard build. I don't think we can remove it.
No worries. Okay. Yeah, that's fine.
Okay.
Thank you.
Ari here. If you can't remove it, is there an option to add like next available? I'm sure it's probably there instead of a specific doctor.
We could test it. I don't know if there's a option for that. Let us look into that. Does anyone on the call know if you can put in a group or?
Generally, I don't believe we can. We definitely can test it, but it's not likely.
Not likely. Often what I have seen done before is that we've put in the champion, so it always went to the one specific provider, and then people always knew. But I don't know. I don't think there is an option to put like a group or.
Okay. Yeah,
Yeah.
I think
Sorry.
that's fine. Because I think it's most of the time, because it's not essential, it will likely just be left empty. It just might create a very awkward situation where, like, if we have, for example, a request or referral to a very specific doctor, but because we do a rotational basis, that doctor might not be on for like 8 weeks. So it just creates a very awkward situation. But I think this is just something for the providers to get used to.
Okay.
Yeah. No worries.
Yeah.
It should be okay.
Ari here. From my understanding, with these referrals, it goes directly to that doctor then, right? And then they have to accept the referral before it goes to my inbox, or does it go directly to my inbox and then I can just book it with whoever I need to?
For this clinic, because they are kind of self-refer, like in ED, they consult the ACS surgeon first. Post-op, they refer their own patients to this clinic. They are actually, it doesn't get sent, like it does go to your requests list.
It falls in the queue.
Yeah, I will show you that in a bit, but it'll fall into your queue to book an appointment.
Well,
So
as
this,
long as I see it,
Mhm.
then it's fine. I guess the doctor that's put into that slot is irrelevant because I'll have the choice anyway to book with whoever.
That is my understanding. They'll be booked into the general, like the Gen Surge resource as any, regardless.
Yeah, exactly. Like we're aware that you work as a pool or a group, and then however so often, whatever the rotation is, we'll show you how we're building the scheduling in a moment. And then so once this falls onto your queue, or you can pick it up and schedule it accordingly.
Sounds good.
Was very discussion with this. But moving on, from visit modality, it will be, there are options, and I believe that's something we cannot change, but in person in the clinic is what this clinic usually does. The location drop down, when they select it, there's only one option in the build. So Richmond, it will be RHS General Surgery Rapid Access Clinic. The reason referral be filled up with a provider, and then interpreter, if it's required, will also be an option. And then if they want to CC another provider, they can do that as well. Any more questions about the rest of this order? Not, I will move on. So this is the reference text that was sent to Ari and Jonathan last week. We do have a little, kind of a big comparison slide as well in the next slide. But just going over it again, we have our clinic name top, right at the top, our phone number. We have the clinic hours, the population served, and all this was taken from the referral forms. What is required before referring to this clinic? So the referring provider must ensure acute care surgery was consulted and reviewed patient EEG. Diagnostic assessments are not available on certain. Sorry, do you need me to reread all of these?
Oh, you're good.
Would you
I
like to
skipped
read
it. I
it?
think it looks okay.
I
Ari,
know
high
did
level
see
looks
it.
good.
okay too.
Too.
Yeah,
Oh
looks
yeah,
no,
looks
you're good.
good.
Don't worry.
Okay, thank you. The only thing I added since last week was the working monitor number, and that's the only thing I changed, and then updated the phone number, of course. And just looking at the slide, I'm very sorry, it is a mess. But basically, I'm just comparing future state, which is on the left-hand side, and the current state, and just mapping out where we kind of applied everything. So there's nothing missing. Would you like a few moments to look at this?
No, it looks good.
Okay,
Yeah.
thank you. Sorry about this.
Looks good.
But
No,
we
it looks
tried to
amazing.
map it out.
Yeah, it looks great.
Actually, very clear.
Okay, well, thank you. Thank you to Michael, our other manager, for this. If not, then we will move on, and the referrals validated then. For registration, we are going to go into our scheduling appointment book. So the bookshelf name will be RHS General Surgery Rapid Access. The appointment location, with our EDD, this might change then, if it's RHS Gen Surge RAC or just RHS GRAC. Automated appointment reminders were not something this clinic desired. And the appointment types in the scheduling appointment book would be the RHS Gen Surge New and the RHS Gen Surge Follow-up. And the orders that are attached to these are the referral to outpatient RHS General Surgery Rapid Access for the new one, and the follow-up clinic RHS General Surgery Rapid Access for the follow-up one. And both of these would fall into the ambulatory rapid access future request list. And I will show you in the next 2 slides what this will look like. And of course, the location will be RHS General Surgery Rapid Access, and it might change depending on what, if we're renaming this. Any questions about this slide at all?
Ari here.
Yes.
So for the automated appointment reminders, we probably said no for
Yeah.
the new patients just because they're usually booked within a couple days. But the odd times I do book 2 to 4 weeks out because of surgical follow-ups. I'm sure I could change that, right? Because I think with the booking process, I will be able to select if a patient needs to be like reminded a couple days before or something when I'm booking it. Or is that something that can be standard, like 2 business days ahead or something?
I might have to
Hey,
defer
this
to-
Josh.
Yep, Josh, thanks.
Yeah, it's Josh. So the way it works is kind of like you were saying. So you set it up based on how far in advance you want the calls to go out. Like you were saying, we can definitely have it call for the follow-up appointments only versus the new appointments, so that there's no issue there. And then again, like you were saying, yes, you have the ability to control, based on what the patient says, that yes, they do want to be called for this appointment versus, maybe another future follow-up appointment. It is based on the individual appointment that you're scheduling at that time. So you do have control as far as, what we can turn it on for, like you were saying, new versus follow-up. If we only want it to be turned on for follow-ups, we'll just, designate that and build it out that way. And then to take it a step further, like you were saying again, yes, if I determine, at the time you're scheduling me, yes, I do want to be called, you have that ability to make the option, whether it's for text message, phone call, or email. So, and that would just be based on my preference versus, your preference when you're scheduling. So.
Thank you, Josh. Is it possible to just turn that on and let's just make it yes to be safe? I mean, if I'm booking for tomorrow, it's not like they're gonna get a reminder because I'm talking to them like 1 day ahead, right? But if for the system, anything like anyone booked 2 days out will get a reminder. Is that enough? Like, can we just change that
Right.
option?
Yeah. Yeah. So I believe at one point in time I sent you guys over the questionnaire to fill out. It has some of those details in there where, yes, if we do decide to call 1 day prior to appointment, then like you're saying, if we're talking today, obviously that's going to serve as a reminder for my appointment tomorrow. But if we scheduled me, today for Monday, for instance, then I would be collected in the group of calls that's going to go out tomorrow for that Monday appointment. So if you have that questionnaire handy, if not, I can send it back over to you guys. Just fill it out as appropriately, and if you need help, then obviously I can jump in and help you with it, just to
it's
make
okay.
sure that we're getting things notated correctly. So.
Oh, I'm looking at it right now. So the question was, do you currently
Okay.
provide reminders to patients? And I said no to that. But then the next one says, how far in advance will your reminder be sent to the patient? So will. So I'm thinking CST now. And I said 1 day.
Yes. Yeah. So that's possible. Yep. I think the extract would run early morning, like today, for the calls that need to go out today for tomorrow's appointment. So obviously, like you were saying, if we're scheduling this afternoon for a patient tomorrow, then you speaking to them now is going to serve as that reminder, if you will. But anybody scheduled prior to, I'll just throw out a time. I don't know exactly, but let's say the extract runs at 9 a.m. Like, even though your clinic ends at 9 a.m., it may, everything that gets scheduled today may get included to go out in the call today, later this afternoon. But definitely, if it was scheduled yesterday, it's definitely going to be picked up today to call for an appointment tomorrow, if that makes sense.
Yep, that makes sense. Yeah, if we could just change that to a yes, please, then.
Yep. And then if you will, just, I think you sent that back to me, right?
Yep, I did.
Question. Okay, cool. So I'll find it, and then we'll get you guys included to make sure that you're accounted for. And when we begin the build for that, if there's anything outstanding, obviously we'll reach out. But it's somewhat later in the process as far as making sure it's built out and then test it. So, but yeah, we'll definitely get you guys clued in on that.
Thank you.
Thank you, Josh. Any other questions about this page? If not, I will move on. And this is just a screenshot of the chapbook. So the name of the bookshelf is RHS General Surgery Rapid Access Bookshelf, or book, sorry, bookshelf. This is the book. And the resource that we'll be booking appointments into is RHS Gen Surg MD. And this is just an example of an appointment that was put in, and you can see the appointment type here and the patient's name. And this is the request list. So you can see it's request list by location. It's the request list queue is the ambulatory rapid access feature request. Location is ambulatory, and location again will change depending on what is accepted for the naming. And this wasn't fully built out when I got these screenshots, so I plugged in another. This is why it looks kind of odd, but this is what it would look like. Any questions?
No questions, thank you.
Moving on, we're going to talk about the message center. So this message center is a virtual inbox that can be maintained and accessed by multiple users. And basically all these members, whoever's on, would be the one accessing and maintaining this inbox. And I'll show you kind of a screenshot of what it looks like, but there will be, right now there's 3 pools that are built out. One being for the general surgery GRAC providers, one for the admin, and one for clinical. And these are the pool members that are in right now. We just need to verify the pool members and also the team leads. And the team leads doesn't necessarily have to say, like for providers, it doesn't have to be the provider. The team lead would be the one maintaining the list. So we just wanted to ask you guys and clarify who the pool members will be and who the team leads will be.
So can I ask, like, this surgeon group, the ACS pool, it changes over time and it depends on the locums and all that. So does that mean that every time there's a change, the team lead would have to add and remove someone?
Yeah.
Okay. I think might have to defer this decision to Dr. Sampath. And again, I think I'd just be mindful of Dr. Sampath's spelling.
Yes.
Yeah, okay. And then in terms of the team lead for the GRAC admin and the GRAC clinical, we can just assign it to Val. We can keep it to Val for now.
These team leads can essentially be anyone as well. So if you have someone like Ari, or like, it doesn't necessarily have to be someone in an operational lead position as well.
For sure. Yeah, no, that's helpful to know. I think it's just because Dr. Sampath would have access and knowledge of the movement with the ACS surgeons and then the total list, right? So I think it would be easier for him to maintain that, but I'll have to speak to him whether or not he wants to take on that responsibility.
Okay. This is something that can be changed as well, so I think it'd be okay. Yeah.
Okay, great. Yeah, otherwise I think if we can just remove my name from those, otherwise we'll be okay. Yeah, thank you.
Thank you.
Wait, Val, just double check.
Sorry, guys. So we're just talking about from the GRAC admin groups? And
the team lead, yeah.
Yeah, I think that's fine. That makes sense.
Cool, thank you.
Okay. And we just want to clarify too, we understand like this clinical pool is usually for nurses and allied health, and we understand that there aren't really specific nurses tied to this clinic. But our team thought it might be a good idea to keep it so that it's built, even though it's not necessarily used, in case GRAC evolves and does eventually have more allied health or nurses on board. Is this okay with you guys?
I think it's a good idea to have it built. I would
Yeah.
remove Maria from that right now
Yeah,
because Maria
perfect.
does it on a consult service, but
Yeah.
it would be good to have that pool built in the future. Thank you.
Okay, sounds good. All right, thank you. And then just, I do understand that these are fluctuating. So in terms of for our builders right now, is this the list that we want to work with?
I can reconfirm the list. I can send you the latest list
Okay,
after
thank
this
you.
meeting.
Thank you. And this is just to show all the names of each pool. And this is what they would be seeing. So in their message center, when they pull up this pool, they would be seeing all the results, orders, documents, and messages for this pool.
Sorry, right now, does that mean that automatically once you build it in, they get all the results, or only when they're CC'd to that pool?
I will need to defer to you, Michelle, or our builders for this too. I'm not too experienced with message center.
I think it's when you CC the pool.
Okay, sounds good. If we
But you
can
know what?
if we can confirm that, that'd be great. Because I would not want every patient to have their results and orders sent to everyone in that pool, because there's like 20 physicians in that pool.
Okay, if a provider is putting in an order on Tuesday because they're leading that entire group, do you want the results just to go to that one provider that placed the order, or do you want it to go to a pool? Like all the providers will follow up on it.
It will be to that provider. Yeah, I
Just
don't
to that
think
provider specifically.
Yeah.
Okay.
that'd
Yeah.
be great.
So I think that's the way it functions, and it would be only if you CC the pool, but I will check on that just right now in the background.
Okay, thank you, Michelle.
Okay, thank you. Any more questions about the message center pools? No, I will continue. We did talk about clinic flags before a few times, and for this clinic, we decided that no clinic flags are necessary. And once again, clinic flags are to identify patients who are being followed, have been followed, or will be followed by a specific care team or program. And you know, once this patient leaves this clinic, usually they don't want to know if they were admitted again. So just to clarify, again, this clinic does not want a clinic flag.
Yeah, confirmed. We don't want clinic flag. Thank you.
That's good. Thank you. And this is something that was discussed by Ari and Andy from our registration team, I believe offline over email, but just to verify once again. So at registration, 1 face sheet will print and 10 external use labels. If clinicians are printing labels through PM conversation, one external use label will print, 2 non-specific blood specimen labels will print, 2 blood specimen labels will also print, and 1 referral demographics label will print. And this is kind of just reiterating what was confirmed over email, and I've also double checked with Andy prior to this.
Yep, it looks great.
Thanks. I just want to confirm as well. So when these are printed at main admitting?
Correct.
That's good. Thank you. So then labels are validated and we will move on to a break. Are you guys doing okay? And
We can move forward. Right.
Yeah, let's move forward.
Yeah.
Okay. So I will pass the torch on to Morgan, who will go over end-to-end future state workflow.
Great, thanks, Carmen. So we're just going to take a quick look at our overall view of what we're going to go through today. So we're going to first begin with the receiving referral workflow, move into schedule appointments, check-in and registration, into provider assessment and documentation, to procedures and treatment if required, and then finally follow-up / patient departure. So moving to the next slide, we're going to begin with receiving referrals. So just to orient you to the color scheme that we have here, you can see in the top right corner that there's a legend. So gray is going to be any actions that are out of system, and blue will be any actions that are in system. So for an ED referral, out of system, the ED patient will be diagnosed with an ACS issue. The ED provider will then place an ED consult to general surgery and ask the ED clerk to page the service. ACS will then consult on the ED patient in person or over the phone, and the ED provider will place diagnostic and lab test orders to be completed in the ED. The ED provider will then place the referral to outpatient general surgery rapid access clinic order, and the patient will be discharged from the ED following our standard enterprise ED discharge workflow. For an inpatient referral, the patient will be discharged or ready to discharge from an inpatient unit. So this patient has had surgery already and they're getting ready to go home. The ACS provider will place a referral to outpatient general surgery rapid access clinic order, and the patient will be discharged following our standard enterprise inpatient discharge workflow. Next, we'll move into our schedule appointments workflow. So for internal referrals, the GRAC clerk will locate the referral in the request list inquiry using scheduling appointment book. The clerk will then contact the patient to obtain consent to send an email to them and then schedule the appointment. The email will contain the scheduling information when it is sent later on. The clerk will then create a pre-register outpatient encounter and schedule the appointment using scheduling appointment book. They will then email the patient the details of their appointment once this appointment has been made. For external referrals, the GRAC clerk receives the fax referral into work queue monitor and will then index the referral form also within work queue monitor. Same as previously, the clerk will then contact the patient to obtain consent to send an email to them and will schedule the appointment. The clerk creates a pre-outpatient encounter in scheduling appointment book and schedules the appointment using this encounter. They will then email the patient their appointment details. Moving on to check-in and registration. On the day of visit, when the patient arrives at the hospital, they will present to the main admitting clerk. The clerk will then locate the patient appointment in scheduling appointment book and will update the patient status to checked in and complete their registration. They will then flip the encounter from a pre-outpatient encounter to an outpatient encounter, and the patient will wait in the consult waiting area for the provider to see them. Moving on to provider assessment and documentation. I'm going to hand it over to Maggie to take this piece forward.
Thank you, Morgan. Is there any questions about the previous 3 workflows? Okay.
No.
Great. Okay. So for the provider assessment and documentation part, on the day of the visit, the provider will review any appointments through your ambulatory organizer, which is located in Power Chart, and we will show you a slide of that after. The provider will open the chart to review any patient's information, and out of system, he will bring the patient to the consult room, which is now 1306B, review the patient and determines the next step. And then afterwards, they will document the visit using MModal or DyneDoc. So this here is your ambulatory organizer, which is in Power Chart. This is your schedule for the day. As you can see, there is 2 patients here scheduled for 7 a.m. and 7:30. Below here under the time, you can see your RHS Gen Surg provider. The patient is scheduled for 30 minutes. you have your patient name and information and gender. And as you can see under the details, you have your GenSurge GRAC follow-up appointment. And you'll see under the notes, you'll see the reason for the visit. Any questions about the ambulatory organizer?
Nope.
Pretty self-explanatory, right? Here is a slide for your example of a Dine Doc. Carmen has created a auto text for you guys here. So under here, you'll see your reasons for referral, all your allergies or past medical histories, any procedures that has been completed, history of like present illness, vital signs, and all your lab results are actually auto-populated from Cerner, so nothing needs to be typed out or anything. Yeah, is there any questions about Dine Doc?
Not from my end.
Perfect. Okay. So we can move on to procedures and treatment. So your ACS provider will review the patient, and they'll decide if the patient needs a wound care clinician assessment. And here the provider will enter the wound care clinician consult order in PowerChart. And out of system, the ACS provider will call the wound care nurse, and the wound care nurse will come and see the patient in the clinic. And this is where the wound care nurse will document using Dine Doc. And I will pass this to Alan.
Thanks, Maggie. So finally, for the last part of this end-to-end workflow discussion, I'm going to be talking about the follow-up and patient departure processes. And again, Jonathan, thank you so much for setting that lovely resource that you gave to us. I think we were able to do this quite seamlessly because of that. So again, much appreciated. So for the day of visit emergency surgery departure workflow, out of system, the provider would determine the patient requires immediate same-day surgery. From there, the provider would call the OR desk to complete the emergency surgery slip. From there, within the system, the OR clerk would create the referral and pre-inpatient encounter. The provider would place power plans in a planned state as required. And from there, the patient would be directed to the surgical daycare. In the case of day of visit community surgeries, the provider would determine out of system the patient requires urgent surgery. From there, they would complete a OR booking package as per the pre-Cerner workflows. And again, we made a note here to call out that the regional OR booking form and consent forms would still be able to be printed from form passed by the clerk RA and completed by the provider here. From there, the provider would call on the OR clerk, and similar to the previous workflow we looked at, the OR clerk would create a referral pre-inpatient encounter. The provider would then place power plans in a planned state as required, and from there, presumably the patient would be going back to the community, waiting for their surgery. So the provider would give the handout such as required, such as the patient discharge handout or they would be discharged from the clinic while they wait for surgery. In the case of elective surgeries, the provider would determine that the patient does not require same-day or urgent surgery. The provider would then refer the patient to the office of the general surgeon on call. And of course, it'd be dependent on the day of the week, which surgeon this would be. From here, the provider would enter the order referral to clinic not using Cerner. From there, the provider would create and complete a visit summary note as needed. And then out of system, the patient would be discharged from GRAC. In the case of inpatient admissions, the provider determines that the patient requires an inpatient admission. Within system, they would discharge the patient from GRAC and create and complete the GenSurge clinic note. Out of system, the provider would call the staff support coordinator or SSC to acquire an inpatient bed. SSC would consult the appropriate personnel to arrange a temporary bed space for the patient, and then mid-meeting would create an encounter while waiting for the availability of an inpatient bed. From there, within the system, the admission process would be followed as per unit, whether they go to SDC, PACU, or ED. And in the case for the discharge, providers would determine patient doesn't require surgery. From there, within system, the provider would create and complete the Gen Surg Clinic note. The provider would place follow-up orders, the follow-up order follow-up clinic RHS, general surgery rapid access, as required. From there, the GRAC clerk would follow scheduling workflows to book follow-up appointments as required as well. And I believe that is the final workflow that I'll be covering. Does anybody have any questions about those departure workflows or any concerns or anything we'd like to call out at this point in time? Okay. If not, we will go ahead and consider these workflows validated. Thank you very much.
Looks good. Yeah.
Awesome. Thank you so much. Well, that concludes this part of the end-to-end workflow. From here, I'm going to pass it on to my colleague Carmen to get into some forms. Thanks.
Okay. So just going to go into documentation first, which we kind of talked about and showed earlier, but providers will be using the general surgery clinic note, and this will be distributed to Accelerus and also distributed to Care Connect. The wound care clinician, when they do see patients, they will just be using the nursing narrative note, and this wouldn't be distributed to Accelerus or Care Connect. Any questions about those two?
Ari here. Is it possible to get the wound care notes into Care Connect?
That is a very good question. And do any of my colleagues know that information? If not, it's something I can follow up with.
It would be extremely helpful if that information is available just for continuation of care.
Just Care Connect?
Yeah. I mean, I guess it's in Cerner, right?
Yeah.
Yeah. Oh, never mind. Let's not open up that can of worms. We're
I
good.
will ask regardless and just let you have that information, whether it does or not.
Thank you. But honestly, it's not a requirement.
Okay, I'll just do it as an FYI for myself as well. Moving on to some documents that can be found on FormFast. So the two that we kind of talked about is the VCH consent, which is just the standard VCH consent form with the medical or surgical consent, and as well as the administration of blood products. Another one that is on FormFast is the regional OR booking form. However, I do understand that a lot of, from what I've understand, is a lot of clinics actually keep a stack of these and they just continue writing on the paper form. Any questions about the FormFast documents? Not, I will move on to my chart here. As I already said, these first two forms, the regional OR booking form and the consent form, will be on FormFast. Pre-admission information will be completed mostly in PM office registration, and the rest are in existing power forms, such as the pre-op checklist. History and progress notes will be documented in using dynamic documentation. Allergies will be in the allergies tab of the power chart, and there are multiple power forms that also ask out for allergies in the basic condition information. Orders will be entered by CPOE. All the referral forms will be built as the referral order and as well as the reference text. And there will be no change to the emergency booking slip, and it will stay on paper. Any questions about our forms?
No.
Okay, thank you. If not, these are then validated. I will just have a little quick note on discharge. I believe we already mentioned it, but so encounters for the RHS General Surgery Rapid Access Clinic location will be automatically discharged at midnight. And the workflow would be, there's an option to print and fax discharge summaries / consult note to the GP. That's just an FYI, depending on what you guys do. And we are going to talk about reports just for a few minutes here. I understand a requirement for a report was brought up during the scheduling design session, and I just want to clarify the purpose of this report. So I have a screenshot in the next slide. So this is the one that Ari said you would like to use, and I just want to clarify the purpose of this report that we'll be pulling up.
Ari here.
Yeah.
This is the report that I will be giving to the physician so that they know who's on the list for today.
Okay.
Yeah, because current process is this goes on in the front of the folder where all the referrals are kept.
Okay. Okay. So on top of the ambulatory organizer, they would also prefer like a physical list to have and look at as well. Is that why we need to pull up this report as well? I just want to clarify.
Oh, there is currently I'm booking out of Outlook and
Mhm.
none of the physicians have access to that.
Right.
So I do have to print out their day list and all their referrals are on paper as of right now. There is nothing online. That is something to ask the doctors if they prefer. It's just they can pull it up themselves. It makes my life easier, to be honest, and
Yeah,
no
for
paperwork
sure.
done, right? And I wouldn't have to leave it in the office while they're not there.
Okay.
I would advocate for this report to be built, just to, as Ari mentioned, if the physicians prefer a paper one versus another physician's preference, right?
That makes sense. Yeah. Okay. I believe these reports, like, they exist. It's just a matter of giving access to. Am I correct in saying that, Michelle, or anyone else who?
They just live within the scheduling application. So this one is, it'll be there to use. If anybody has access to the appointment book, then they'll be able to get to it.
Okay, thank you for clarifying that, Josh.
Yeah, it's about showing you how to find it, getting it.
All right, so it shouldn't be a problem getting you this report then for providers who do prefer that paper list. And another report that our team kind of brought up was this provider compensation billing report. I had an email with Dr. Sampath before where he stated that providers bill MSP directly, but we wanted to present this report to see if this is something that the providers would find useful for their billing.
I think that'll be a Dr. Sampath question.
Okay, that's good.
Thank you.
All right, and that's actually it for our presentation. Any questions? Yes.
For the reports, is there a report that shows the volume, the monthly volume?
I don't know off the top of my head, but I can look into that for you.
Perfect. That'll be good for us to keep track of stats. Just monthly volume and then a type of visit would be good, whether it's a
type of visit and monthly volume report.
Belle, is there anything else you need, Belle?
No, the other thing I was going to say was the type of visit. So type of visit, month volume, and then I'd like to be able to break it down by provider name. Which I think if we're going to be doing volume, it'll tell who the physician was that was involved.
Provider name might be a little bit hard because the way we built the schedule was based on a generic MD, just because of their weekly rotation basis.
Yeah.
But if Carmen, if that's a possibility, that'll be helpful.
I will probably reach out to our reporting team to see if there is a report that exists that can pull all this data.
Perfect. Thank you.
Yeah, thank you. Any other reports you guys can think of that you would need?
No, can't think of anything. Thank you.
Could be it for now. Thank you.
If not, we're moving on to questions anyway. So any other questions? Do you guys have any more questions for our team?
Ari, is there anything you want to clarify?
No, everything looked great. Thank you so much.
Val?
I'm good, guys.
Yeah, thank you. Thanks for all the prep.
Yeah.
Thank you. So we'll have a couple follow-ups that you'll probably hear from us in email, and we also have the validation session for scheduling coming up as well.
Is there going to be one with Dr. Sampa?
Yeah, so I'm moving on to that slide.
Okay,
So we are
perfect.
planning to do a provider validation session. His availability kind of conflicted with some of our UBC Go Live. So I believe the plan is to do it after our UBC Go Live activities. I believe it's January actually. We'll be reaching out to try to get some time with Dr. Sampath then. And then, yeah, our scheduling validation session is October 17th, I believe, from 10 to 12. And then in the future, we will have clinic workshop adoption, and I don't know what those dates are yet. That's quite far off.
Okay, sorry, just one. Ari, go ahead.
Oh,
Yes.
I just saw on my calendar, October 17th, the meeting is at 1 o'clock.
Okay.
Yes, that's fine. That one.
That's perfect. Thank you so much because I can't attend the morning.
Ah, okay. That's fine. We'll change it on our slide.
Yeah, we'll change it.
Sorry.
On our slide,
The validation with Dr. Sampath is in January.
I believe so.
Okay.
Yeah, we were looking at doing it after our UBC Go Live period because
Right.
we're going to start that towards the end of October. And then we were just giving him a little bit of time because no one's calendars aligned. So we were going to do it into January, if that's okay.
Okay, yeah, as long as like if there's any changes that he proposes, as long as there's enough runway for us to get that in before go live, and that's fine with me.
Okay, we'll triple check with Janice to make sure that's okay.
Perfect. Thank you.
One of the things too that I was just creating an EDD for the core location is I'm not sure we'll be able to change it at this point. But I will put the ticket forward anyways because I don't think we should always try, right?
Yeah, and if it's not too urgent or important, so if it's a nice to have.
Okay.
Yeah.
Okay.
Thank you.
We'll try anyways. Okay.
Then if not, then that is the end of our presentation. Thank you so much, everyone, for coming. And we have a few follow-up items we'll be communicating to you all with. So
Thank you,
you.
everybody.
Thank you for your work.
Have a great day.
Thank you. Bye.
Thanks, everyone.
Thank you.